Risk factors of gallstones or cholelithiasis. Ethnicity, family history, and genetics. Epidemiologic data are available from a number of large European and American populations. These studies have revealed a marked variation in overall gallstone prevalence between different ethnic populations. As a general rule, there appears to be higher rates of cholelithiasis in Western Caucasian, Hispanic, and Native American populations and lower rates in Eastern European, African American, and Japanese populations. 2. Age and sex. Age 40 appears to represent the cutoff between relatively low and high rates of cholecystectomies. A higher prevalence of gallstones has been observed in women in all age groups. 3. Pregnancy. Pregnancy is a major risk factor for the development of cholesterol gallstones. The risk is related to both the frequency and number of pregnancies. 4. Oral contraceptives and estrogen replacement therapy. Most studies have shown that estrogen therapy is associated with higher rates of gallstones. Oral contraceptive use also appears to cause a slight increase in the risk of gallstone formation. Women under the age of 40 years and those taking high-dose estrogen preparations have the greatest added risk. 5. Obesity. Obesity, defined as weight greater than 120% of ideal body weight, is a well-established risk factor for the development of cholesterol gallstones. 6. Rapid weight loss and very low-calorie diets. Rapid weight loss is also a risk factor for gallstone formation. High rates of gallstone formation have also been associated with very low-calorie diets. 7. Diabetes mellitus. Diabetes mellitus appears to be associated with an increased risk of gallstones. 8. Cirrhosis. Cirrhosis is a major risk factor for gallstones. 9. Gallbladder stasis. Conditions that result in bile stasis are associated with a higher prevalence of gallstones. In the normal state, the gallbladder avidly absorbs water from bile. Thus, if bile remains within the gallbladder for a prolonged period, it can become overly concentrated with cholesterol, thereby promoting stone formation. Common examples of this mechanism include spinal cord injuries, prolonged fasting and the use of total parenteral nutrition, and excess somatostatin. 10. Medications. In addition to estrogen, oral contraceptives, and octreotide, 2 other drugs can promote the formation of gallstones, clofibrate and ceftriaxone. Clofibrate, a now rarely used cholesterol-lowering agent, is strongly associated with gallstones. Fenofibrate has also been associated with gallstone formation. Ceftriaxone is a major cause of biliary sludge formation in hospitalized patients. Biliary excretion accounts for up to 40% of ceftriaxone elimination, and drug concentrations in bile can reach 200 times that of the serum. When supersaturated, ceftriaxone complexes with calcium and precipitates out of bile. 11. Decreased physical activity. Physical activity is associated with a decreased risk of symptomatic cholelithiasis. 12. Crohn disease. The prevalence of gallstones is increased in patients with Crohn disease. 13. Hemolysis. Disorders associated with hemolysis increase the risk of pigmented. Thank you.